Hello, good morning, good afternoon, good evening, my dear listeners of the Daniel's Blog. I'm the this is Dr. Daniel Kim from Seoul, Korea. I am a hematology specialist. Today I will explain the details on the types of allogeneic cell transplantation donor according to the donor relationship and the source of the stem cell. Uh, Previously, I explained the details on the conditioning of allogeneic cell transplantation and the way how to classify the allogeneic cell transplantation according to the type of donor and the conditioning regimen intensity and the stem cell source. In this session, I will explain in more detail about the type of donor, especially on the relationship between the donor and the patient. First, we can get the allogeneic cell transplantation donor stem cell from the matched sibling donor. We can simplify this pool name as MSD, which means the matched sibling donor. For all kind of human beings, we have some sibling, which means that we have a brother and sister, and all the brother and sister will have the same HLA typing from the same parent. So if a parent have a type of AB HLA typing and the mother has CD typing, and the children will have four kind of combination of HLA typing. So the HLA molecules can achieve from half from the one each parent. So the one of the children, one of the child will have the AC combination. The other another will have a AD combination. Another will have a BC, and the rest will have a BD combination. So basically, when a patient have ACHRA typing, the possibility that the patient will have the same identical HRA sibling will be 25%, because all the sibling will have four kind of a different combination of HRA. So if one of the patient one patient have AC combination, and the patient will have the possibility of 25% of a possibility that he will find the same HRA typing from their sibling uh, the family. So we can mention this kind of donor as matched sibling donor, and when we find this kind of matched sibling donor, we can check just simply the antigen specific HLA typing, because the molecular typing will be same if the antigen specific type will be identical, exactly identical. And we have the major histocompatibility antigen and the minor histocompatibility antigen. And if the major antigen histocompatibility antigen are the same between the two siblings, and all the minor histocompatibility antigen, in other words, the HLA antigen will be also same, because these all the HLA molecules comes from the one parent, and the other from other parents, and they will move in a always in the pair way. So the matched sibling donor is at any times the best available donor when we do the allogeneic cell transplantation, because all the major and the minor HLA will be exactly same, and the possibility of graft rejection and the GBHD instance will be very minimal for this kind of matched sibling donor. But nowadays, we don't have enough children to have all the identical matched sibling donor, in case that one of the children will have the hematology disease, which requires the allogeneic stem cell transplantation. So in case that we cannot find the matched sibling donor from our siblings, we needed to find the matched or related donor from our donor registry. Each country has their own donor registry for the hematopoietic stem cell transplantation, and we have to check the HLA typing, which contains 10 sequences, including A, B, C, DR, and DQ. And these all the antigens will move in a pair way. So we have A1, A2, B1, B2, C1, C2, DR1, DR2, and DQ1, DQ2. So we needed to check all the A from A to A DQ2, all the sequences from the patient, and we needed to find the matched unrelated donor from our donor registry. All the donor registry have their own sequence of the possible candidate of the allogeneic stem cell donors, and usually all the registry have only A, B, C sequence for all the possible donor candidate because of the shortenings of the budget. And when we find the allogeneic stem cell donor candidate for the matched donor-related donors in the donor registry, and we have to check the intention to donate their hematopoietic stem cell to the patient. And if the possible candidate agree with the donation, we have to check the all the molecules, including the DL and the DQ. And when we find that all the 10 sequences of HLA molecules are all identical between the patient and the donor candidate, we call this kind of donor as matched unrelated donor. And in these cases, we added the another terms, which means that all the 10 HLA sequences are identical, and we call this donor as pool matched unrelated donor. But sometimes when you check all the 10 sequences of HLA antigen and the genetic data, sometimes one of the genetic sequences is different between the donor and the possible candidate of allogeneic stem cell donor, and we call this kind of relationship as partially mismatched unrelated donor, in other words, PMUD. And when we use this kind of partially mismatched unrelated donor, we usually accept one locus mismatched antigen donor. And in specific situation, we can use the two Rosai different allogeneic stem cell transplantation donor from the unrelated donor. This is partially mismatched or acceptable and unacceptable. We can classify one of the situation, but in general, usually when we use the partially mismatched donor from our donor registry, we usually accept one locus mismatched donor and the donors, the possible candidate of a donor which has the two loci different from the patient sequence will not be accepted in general, because if the molecules of HLA, the difference is increasing, number of differences increasing, the possibility of a graft rejection, the possibility of a GVHD instance is also increasing, and the possibility of a failure of allogeneic transplantation is also can be increasing. So nowadays, instead of using the partially mismatched donor, we usually use the familial mismatched donor. So in other words, I will back to the first explanation of the relationship between the parents and the siblings, offspring. And if the parent has A, B, HLA sequence, and the mother has C, D, and all the offspring will have one of the four possible combination of HLA sequence AC, AD, BC, BD. So basically, when one of the patient is diagnosed as hematopoietic disease, including the acute leukemia or aplastic anemia, and the AC, and the relationship between the parents and offspring will be always haploidentical familiarly haploidentical. So in other words, one of the HLA molecule settings are always identical, but the others will be different, and sometimes they can be but and there will be some possibility that we can find the haploidentical family mismatched donor from our siblings, because the two of the sibling donors, so siblings will have the 50% identical genetic information, genetic sequence. So these two siblings will be identical, haploidentically. But in this case, these two donors, these two offsprings will also have the 50% identical, which means they are haploidentical. So basically, for the relationship of the parents and the offspring, they always will be haploidentical, and we can find 50% of chance to find the haploidentical donor from our siblings. So we always have the possible candidate of donors from our family when we decide to use the family mismatched donor or haploidentical family donors. So nowadays in Korea, we use first matched sibling donor because it has low possibility of graft rejection, and the instance of GVHD is very low. But in specific situations such as the acute leukemia, the lymphoma and myeloma, the graft versus leukemia or graft versus tumor impact will be also important. So in this case, all the possible outcomes will be identical between the matched sibling donor and the matched unrelated donor. But for the aplastic anemia, the graft versus leukemia effect cannot be expected. So in this situation, especially for the aplastic anemia, the matched sibling donor is always preferable to the matched unrelated donor. But except the very specific exception, we can use both of the matched sibling donor and the matched unrelated donor with the expectation of the same efficacy and the same complication rate. But when we cannot find the matched sibling or matched unrelated donor, we can use the family mismatched donor or haploidentical family donor, because the availability is very easy, and we can find always the possible candidate from our family. And we can classify the donor type according to the source. We can use the bone marrow stem cell from our donor candidate, and we can do peripheral blood stem cell donor from peripheral stem cell from our donors. In all the situations, these two kinds of those stem cell sources are almost the same outcome. We can expect almost the same outcome from the bone marrow stem cell and the peripheral blood stem cell, except the allogeneic stem cell transplantation for the aplastic anemia. For the aplastic anemia, the bone marrow stem cell is always preferable to peripheral blood stem cell transplantation, because the bone marrow stem cell has the low chance of graft rejection and the GVHD. Except the aplastic anemia, we can use the bone marrow stem cell as well as the peripheral blood stem cell in a very almost the same expectation of the outcome. So we usually use the peripheral stem cell source in nowadays because it can easily access the patient graft stem cell because it can just correct the stem cell from the peripheral blood of the donor after giving some kind of some conditioning, such as the GCSF and some sort of priming regimen, very in a very simple way. But for the bone marrow stem cell transplantation, we needed to do some kind of invasive procedure, such as the general anesthesia and the direct invasion of the pelvic bone puncture, very painful and very hard way of achieving the allogeneic stem cell source. So I will summarize my talk. We can classify the donor type according to the relationship in a matched sibling, matched unrelated, and the family mismatched, or the haploidentical family donors. And for the matched unrelated donor, according to the difference between the HRA molecule, we can subclassify the matched unrelated donor as pool matched or partially mismatched. And for the partially mismatched, we usually use one locus mismatch donors, because if the number of the HRA difference increase, the chance of graft rejection and the GVHD instance will be also increased. And we can classify the donor stem cell according to the stools into the bone marrow stem cell and the peripheral stem cell. And we usually prefer to use peripheral blood stem cell because of the easy accessibility of the peripheral stem cell, except the situation that we have to do the allogeneic stem cell transplantation for the aplastic anemia. Okay, I will finish my talk for this topic, and thank you very much for my colleague. And I expect that all the patients who are suffering from those hematopoietic cell disease and their family will be happy and healthy. Thank you again.